Jeremy, are you ready to take over?
I am now unmuted.
All right, take it away.
Okay. I'm gonna share my screen here real quick. Let's see. Desktop. Oops. Can you guys see it okay?
Yep, you may want to put it on, on your
Okay,
slideshow.
perfect. So first of all, Project Echo, I need to thank you. You are the only reason I shaved today because I have to present my face to you all. So I want to thank you for that. But I'm excited to talk about it. Just like Dr. Faust had mentioned, like the purpose of this is an introduction. I find myself even struggling with using consistently some of the techniques. And in fact, if you use the techniques in a way that don't feel natural, it kind of comes across in kind of a disingenuous way. So it's important to just take it in, listen, see how some of your approaches already are kind of following this and what small ways you can even kind of move towards this as a means of engaging with patients. So introduction, complete your pre-test, please. So the objectives. Give me 1 second. I'm going to move something out of the way. Okay. So again, we're going to just explain what motivational interviewing is. We're also briefly going to talk about some of the stages of change and why that's pertinent for motivational interviewing. And then just describing how to begin to implement, not mastering, but just beginning to. So, oops, let me move this down here. Miss Kylie, I did send you an updated one. I just put some notes on here. Primarily, this is for myself, but just to kind of move the presentation along. So what is MI? The whole goal of it is, as opposed to it being like a type of psychotherapy or therapy at all, it is an approach. It is more of like a posture of engaging with a patient in order to help increase their own natural strengths to propel them in a way that is going to be more helpful for them. Sounds very vague and very lovely, and we'll talk about more what that is. So specifically, especially in the field of substance abuse, some of the ways that we engage, in the world of medicine, we get symptoms, we make a diagnosis, and we put it out there. This is your condition, and this is the treatment that you need. And then for some people who aren't even ready to acknowledge the fact that they have a substance use disorder may experience that as very shaming or condemning. So, one of the first initial steps is to just be aware of where your patient's at and just as you deliver things, listening to how they respond. So again, it's an entire posture that's meant to help move things in a way that is more encouraging, collaborative, as opposed to coming across as shaming, blaming, or condemning. So these are the stages of change. Again, up here, this is where most people may start. So you have stages of pre-contemplation, like I'm not even thinking if I have a substance abuse problem. Contemplation, maybe I do. Preparation, okay, I'm pretty sure I do, but I'm not ready to act. Then you actually have acting on the plan, a plan for maintaining changes, and then in the event that there is a relapse, moving back and forth. Again, the reason that there's bi-directional arrows here is that it's very fluid, things move back and forth, and it's the whole purpose of motivational interviewing, although you can really use it at any stage, is meant to help address issues, especially around pre-contemplation and contemplation. We know that the action of substance abuse treatment or medication-assisted treatment would be a great action, but they're not there yet. So what do we do to help move them? One of the things you'll hear throughout the presentation is focusing on listening and using the patient's expertise and experience. What do we mean by that? So you are still the provider, and it's still important, very important to, as you do these skills, I think, and we'll talk about it in a little bit, one of the hardest things for me is that because the whole approach is a kind of harm reduction where you meet the patient where they're at and you kind of look around as they're talking to see, okay, given everything they've said, what's the best direction we can move forward? Even if it's not the level of care or even the intervention I thought, what's the closest next thing we could get? And now in the midst of doing that, though, it can be kind of scary because some of our patients have really bad ideas about what the next best step is. And so it can be kind of a scary thing to say, okay, let's go forward with that. So, but it's not exactly that. What you're doing is you're learning like what motivates, again, what would be some of the potential pitfalls. It's more of a conversation. Again, it's not, and I think I talk about it on the next slide. Yeah, it's not following a patient into self-guided doom, but it's meeting them where they're at, and then with the techniques, helping them to move forward in the most healthy way possible. So this is a motivational interviewing roadmap. So step one, engaging with the patient, having a posture that's non-judgmental, very open, focusing once, we'll talk more about the specifics into it, but focusing on the specific issue at hand, evoking. Some of the techniques are really going to use, the patient's, again, own words and experiences to help evoke a sense of direction, again, towards these healthy goals, and then actually coming up with a specific plan. So this, I know this is a slide that's going to come up later. And again, this is the toolbox of everything motivational, motivational interviewing. The creators were Miller and Rolnick. And again, the depth of this presentation is not one that we'll be able to talk about each one of these. We'll talk about some examples later. Another way, I remember when learning this in training, and this was an analogy that one of the physicians had lent to me. You know, we talk about this idea of introducing ideas or planting seeds. Like, we know somebody's not ready, but let's just plant a seed that will blossom later. And for some people, even the idea of planting small seeds is intrusive, and again, it's judgmental. So the whole approach, as opposed to planning anything new, is just unearthing what is already there. Respect what's already there, because even though we think we may have the right approach for the patient, if we can't align with them, it's never going to happen. So again, we have the stages of change broken up into different sections. Again, motivational interviewing is really indicated, again, for helping people come from a place of contemplation to preparing to act. And then you have the treatment and relapse prevention, so action maintenance phases, which, by the time somebody's already committed to treatment, you're not going to have an hour-long conversation of, are you sure you want to do this? You need to make sure that the actual services that they're getting are matched to where the patient's at. So another example would be this. If we don't have something like motivational interviewing in our toolbox, and all we have is MAT, relapse prevention, and family involvement, again, we're not meeting them where they're at. So for example, somebody that's kind of deciding, do I have a problem or should I do anything? If we start talking about involving their family, no, please don't do that. Don't involve my family. Or if we come up with the idea of relapse prevention, medication-assisted treatment, again, to some people, that might be just completely abhorrent. So having something like this is really critical, especially for individuals who aren't quite at the stage of realizing they need action. So how do you begin? It's the beginning part can be kind of fun and interesting. We got to kind of step outside of what we might typically do as providers. And it requires being a lot more kind of just humble, curious, don't judge. In some ways, this is really similar to like a healthy approach that one would take even with like an adolescent. And that's not to be, talking down in any way, but it's a situation that I think lends itself to giving a helpful example. We can't be super prescriptive to an adolescent population because it creates resistance. Versus if we just start a conversation and truly try and get to know our patients, especially around issues where we think that we could help them make better decisions, we might actually get some content of what they're saying to help guide them in that direction. And again, this goes back to the idea of your patient is already the expert consultant. Although we might know the best thing for a disease state, they are going to know themselves better than we ever will. Sometimes that's actually a really helpful statement to make, especially if there is resistance, or sometimes if I'm with a patient, I'm suggesting something that is against absolutely what they want to do. I almost kind of just, physically lay that out, like, I know absolutely in terms of understanding, like, you know, where you're at right now, what you're feeling. You are going to know yourself way better than I ever will. You know, however, and this is maybe not the most motivational interviewing, but you still retain that role though the whole time. Is they're not the expert on everything, but they are the expert on them. Again, it's super important to be mindful that at the end of the day, you're still responsible for following a appropriate course of action in terms of what's medically recommended. So it is kind of it can be a difficult thing to try and do both. And again, hopefully we'll get some examples here shortly. Again, just to begin to be curious. It is, again, if you use just the MI jargon, sometimes it comes across as kind of like, it's like when you borrow a pickup line and it just comes across as being horribly disingenuous, falling horribly. So again, it's important not to just, you know, think of these as little tools that you can break out. Again, the biggest thing is just to be curious, get the patient talking, get an idea of their sense of values. A big way of doing this is open-ended questions. I mean, these are things that in the midst of a conversation, you've identified a problem, there's some resistance in going the way that you think is indicated. It's then just kind of stopping and finding out, okay, what is important to this patient? You know, who does your patient call when they're in distress? What is your patient's loves, whether it's people, things? And it's important in the midst of moving forward. What am I trying to say? Well, and I'll talk about it again later. So an idea is this, you know, we, again, have it in our mind, what is the absolute right thing for somebody to do. And so often I think we're used to people taking our recommendations. And there's this phrase in AA called attraction versus promotion. You know, if we keep kind of having to promote things to our patient, eventually that might kind of fall short because we can't be a cheerleader forever, although it can be very helpful at sometimes. But if you can unearth things that naturally attract them to something, I mean, that's going to create long-lasting maintenance. For example, if you can help link somebody to sobriety, or their sobriety to truly having better health outcomes, if that's important to them, or, you know, relationships with their children. I mean, so it's not just about having kind of like a touchy-feely conversation, but truly finding out what's important to them and then linking that to the ultimate goal. Oh, look, there it is. Attraction versus promotion. It is really easy, especially when people seem really resistant, to say like they're just totally unmotivated, or they're difficult, or they're, you know, stuck. There's so many things I think that come up because, again, these interactions can already be kind of emotional and difficult and unusual for us. So it's important, though, just to have that phrase in the back of your head that no matter what the situation is, no matter how immovable somebody's being, something is motivating them. You know, and just as an example too, you're sitting with somebody, you're having a conversation, you've just had a 30-minute conversation, it's been nothing but resistance. One thing you can do is just to say, listen, I know that you don't feel like you have a substance use problem. I know you don't want treatment. However, you have had a 30-minute conversation with me about that, and you've stayed to even have that conversation. So tell me, why did you even, what was so important about this that you even, you know, you maintained through this whole conversation? You're still here, we're talking about it. It's, again, using anything you can to help drive a conversation, but from the patient's point of view. I think the next slide we have Maslow's hierarchy of needs. So again, some great categories in terms of where to go to try and find what are the needs, what are the loves. Again, the whole purpose of this was to help and identify that before somebody can actually feel love and self-actualize, they need to make sure that they're safe and not going to die. You know, a weird thing about this too is that, again, this is a disease of things not making sense. You know, we might think like, you know, hey, your liver is going to be toast if you keep doing this. And that might not mean anything to them. It may be more of a sense of loving belonging, or it might be that if I don't use drugs, then I don't have a safe place to sleep. So again, coming from the patient's perspective. So again, if you, as starting motivational interviewing is as easy as just being ready to understand your patient, and then remembering the 4 processes. So the first one is engaging. And really, this is all about having an open posture, open-ended questions, allowing the patient to feel respected and listened to. Sorry, I gotta move. There we go. And I say that too, just because it's something as simple as this that really can even help resolve or dissipate resistance. It kind of made me think akin to something. I remember being in residency in psychiatry and thinking, you know, half of my job, it feels like sometimes, is convincing people that they're not crazy and that there is hope. You know, it always seemed like in all of the interactions, no matter what it was, that those were 2 really common themes. And that is actually the whole purpose of engagement here. You know, they're not some 3-headed monster. They're not something that we've never heard of before. You know, we're not going to judge them like you're not crazy, and that there's a level of understanding. Otherwise, again, that feeling of shame, blame, condemnation can be there. And also that there is hope. So that's the whole posture of engagement. Next is focusing. Even though you might know, again, the best, most indicated treatment of choice for them, the goal is to come up with a focus on a common purpose. You might not agree at the end of the day what the plan should be, but it's specifically naming a course. So for example, you're engaging with somebody and they indicate that they're unemployed, not accessing medical care, staying up till 3 a.m. every night. This is important too, just because oftentimes in some of these sessions, there's the list of concerns or potential issues is so much. So, but through the process of engaging, you've identified these things, and then a focus could then be on potentially linking them to a primary care doctor. Sounds very simple, not very much motivational interviewing, but in addition to helping evoke another really great thing that motivational interviewing tools do is help people identify that there is a problem just by getting them to talk about it. And then, so we know what the common focus should be. We've engaged to do that. But the whole purpose that, you know, motivational interviewing was created was that for individuals that for some reason, that next step of like, okay, I know what I need to do. This is the recommended plan, but it's the, from A to C, there's this B going on, that resistance, that for whatever reason. So some of the more challenging but super fun and helpful tools that are a part of motivational interviewing involve evoking what's called change talk. So let me see if I have that. Okay, I do have that as an example. So this was a slide that I added that's meant to help give an example of this. So for example, you are with Mr. So-and-so. You are doing your providery job. You've done a great job. And you say, having had the opportunity to work with you for the last 6 months, reviewing your PDMP and your last urine confirmation, I'm concerned there's an active substance use disorder that needs to be addressed. I recommend you seeking treatment. And then you get this resounding, no, absolutely not. And then there's this litany of things that kind of come out. So it's one thing to create an atmosphere where you're just allowing somebody to talk, allowing the conversation just to be open so that you can find out what's important to the patient. But at the same time, again, sometimes they'll say things that are just, how do I work with that? Or, oh my gosh, this is so much worse than I thought. So, and it's meant to look scattered here because it feels that way. No, I don't need substance abuse treatment. I can stop when I need to. By the way, my wife won't let me see my kids. I seriously don't have a problem. I had a friend take Xanax and they said that helped out with pain. This was another, when this was presented to me, motivational interviewing, there was a slide just like this that our professor used. And some of the goal is this. So if you look at the bottom of the screen, so they are here, I don't have a problem. This is the indicated treatment. And there's this, again, there's this gap that you want them to get over this way. What you do is in the process of engaging with them, you lay out all their thought content. Just take a mental note of what have they said right now? Is there anything there at all that I can amplify or present back to them in order to get them to move even one step closer? So for example, they've said no, that they don't need treatment. Some of the less confrontational aspects of motivational interviewing might just be to expressing empathy. So, they've said absolutely no, my wife won't let me see my kids. That must be super difficult. We're not talking about substance abuse treatment right now. I'm trying to keep momentum with the conversation by just talking about the devastation of not being able to see your kids. That is something that just keeps the conversation going in a way where hopefully eventually we can then tie sobriety to a better relationship with their kids. On the other hand, a more confrontational approach within motivational interviewing, and it's meant to not be confrontational, is this idea of developing discrepancy. So they say all this, and from the content I laid out, I say, sir, Mr. So-and-so, I hear what you're saying, that you feel like that this is not indicated and you don't have a problem. However, I also hear you saying that you had to be Narcan in the last 30 days, and it appears that you have overused your prescription. So help me understand that. And again, that's another kind of useful phrase to put in there. You can just put out two things that came from them that don't make sense. And the idea is hopefully that they'll identify that, yeah, you know what, maybe there is some discrepancy. And then that discrepancy hopefully will be enough to have them take that step forward. I'm stuck. Wait, here we go. So there is, so this is 2 pearls for helping to evoke some of that change talk. So one thing that happens a lot in motivational interviewing is, and it could be anything from smoking cessation to sobriety in general. You ask them, okay, on a scale of 0 to 10, how important is alcohol, being sober from alcohol to you? And to be honest, most of the time, and we can let people know, it's actually pretty normal to feel ambivalent. If you were just 0 or just 10, that might actually be kind of unusual. So, you can give them permission to pick something in the middle too. So they pick the number and they say, well, it's a 7. On a scale of 0 to 10, so even if it's important to you, how confident are you that you can do it, that you have the tools to do this? The interesting thing about this is that it helps, again, create a conversation. So if somebody says, this is so important to me, I want to lose weight, it is so important, how confident are you that you can do that? Like a 2. Well, then you know that the next steps would be, you can then kind of offer, well, would you like to talk about some strategies or things that you can use to do that, to lose weight or to stop smoking? Again, it creates that space to identify a need. Another interesting thing too is as you're working with somebody, because again, it's not something that happens just in one session. It usually takes a couple of conversations. So let's say the first time you talk with somebody, that Mr. So-and-so, well, how important is it to you to, manage this issue of problems with opiates? And he says 0, because I don't have a problem. So then he comes back 2 weeks later, and this time he's actually saying it's like a 2. I'm starting to see that there's an issue. Well, then the question is, so you went from a 0 to 2. What happened that happened? Why did that go from 0 to 2? Can you explain that to me? And maybe they'll talk about something that happened, something worsened in their psychosocial circumstances, or they got bad health news. But again, you're taking the conversation in a way to help increase the evidence and pushing them towards that more healthy action. So the ultimate goal, and again, like I said before, sometimes if it's not genuine, it can just feel disingenuous and kind of weird. Another way it can kind of feel like is kind of closing a business deal. You don't want to sound like a car salesman when you do this. But it is important that once you've taken a patient from, I'm not sure if I want to do something, to, yeah, I see it's time to make change, that you don't want to just leave it at that and be like, all right, well, good luck with that. Drugs are bad. You actually want to help them leave at least with some kind of concrete next step. Because it can actually be a pretty demoralizing thing to be taken to the point of I'm ready to do this, but the guy that just told me I could do this didn't give me a plan. I think I'm just going to do drugs. It's important that next step, if you get somebody to the point And then as a rule of thumb, make sure that the plan is specific, measurable. You're going to have a first appointment with this addictionologist within 2 weeks, or you're going to attend one 12-step meeting before your next follow-up, and we'll talk about what that was like. And then I think, yep, okay. So this again, and I think we already talked about some of this, this was a chance to highlight some of the specific tools in the toolbox. Some of them just to kind of, again, point out, if you're finding like you're having tons of resistance with somebody, there's this idea, again, of momentum in a conversation. If you feel like you're doing this with a patient, you take the conversation to a different place. You avoid arguing, and you express empathy. Like, I hear what you're saying. Like, you have excruciating pain, and you're identifying that what we're doing isn't helping. The last 3 doctors that canned you, don't say that, but the last 3 doctors that you were at also couldn't help you. Please tell me about that. And again, it goes from a posture of this to, again, aligning with the patient. And you're just constantly kind of looking for that one thing that they let slip that you can be like, I can use that. Again, whether it's to develop discrepancy. So the other thing too that's actually kind of easy is that, well, once they get to a point of actually generating some reasons, rationale, or, you know, steps that they want to make a good choice, is you just present that back to them. So of everything that you just said, let me think. What would I want to present back to you to tell you, like, hey, this was good. This was a really good idea. Or just in general, I know we talked about it a lot, but I think I heard you say that committing to sobriety is now way more important to you than it was before. Is that correct? And again, going through everything and learning all these skills is too much for just this. But if you can be curious, if you can identify if you're aligned with your patient, and if you can at least get to the point of looking at what they're saying and saying, oh my gosh, like, I know this was like a 30-minute like session of so much, but is there anything that they said that I could present back to them, just so that we can get them into taking one better step forward? So this is a summary slide. MI is designed to activate patient's own motivation. Change is malleable and form the context of relationship. This is good stuff. I should have said this. MI connects health behavior change with what your patient cares about. And that is, again, it's that attraction versus promotion. So, and again, it is an important thing. You can bring 3 experts to tell a patient something, but if you can bring something that they've said back to them, I mean, it's hard for them to contradict themselves. And that's actually something to watch out for. It's not this, well, let me tell you what you said last week so you can feel super dumb right now. It's I know you've just said that, but last week you said this, and I know that this is important to you. What happened to that? So anyway, that's it. Do your test, get credit, and that's it.
Thank you, Dr. Carpenter.
No problem.
This is Lisa again. I think we're all still seeing Dr. Carpenter's screen, but
I'm sorry,
Kylie,
to you.
That's okay. Kylie, can everybody hear me still?
Yes, we can.
Okay. So I hope that I managed expectations at the start well, and that nobody feels bad because they don't really quite understand everything that we just went through. You know, I was thinking about, as you were talking, Dr. Carpenter, it's the Olympic season, and I always think about motivational interviewing like downhill skiing, and not everyone is a downhill skier, so this may not be relevant, but there's a tendency in downhill skiing to lean back in your skis when you get scared or you get uncomfortable, and then things really start to fall apart. And leaning forward when you're in a situation that feels unfamiliar is really sometimes difficult to do. And I was thinking, as you were talking, about how the traditional role for providers of needing to be competent and needing to have answers that we push forward it's really uncomfortable sometimes to sit back and be in just a curious position of saying, well, I don't know the answers, you know the answers. That can be it can feel like you're out of position, and it's uncomfortable to learn to do that. So we wanted to kind of try to take this in bite-sized portions. And I was talking with Bethany Peterson, who you all have seen and heard on the call before. And the reason I was talking to Bethany about this is because she is a motivational interviewing expert. She does this all the time. And more importantly, she works with primary care providers. And so we were talking about how to make this less overwhelming. So I would like to turn this over to Bethany for a little bit to talk about how she introduced this with her team in her primary care setting and began to make it reachable and actionable for primary care providers to take some baby steps that could help them with some of the early competencies that they could see some immediate rewards with. And then I think we're going to ask you to give us some feedback about whether you like the idea of what they did in their clinic so that we might make that actionable with our calls. Bethany, are you there?
I'm here.
Okay. You want to chat a little bit?
Absolutely. I made notes, and my notes, you could see them, they look like that slide that Dr. Carpenter was, where everything was all over the place. So bear with me, but thank you, Dr. Carpenter. That was awesome. I have to just reiterate what Dr. Carpenter said, and also what Dr. Faust is saying, that motivational interviewing is really hard. And the reason it's hard is because it does feel awkward. It's a little bit different way of having a conversation with a patient, but it is hugely successful. And the reason for that is because it's not just I'm the provider, you're the patient, you have to listen to what I say. Patients feel validated, and they feel listened to, and they feel like you truly care about them. So bear with me, because there's a lot of like I said, my notes are all over the place, but every time he would say something, it would trigger my memory. But we originally in our clinics, in the primary care clinics, had to start small, obviously, because like I said, it's hard to learn it, and it's even harder to use it with patients and practice it. So we had, it wasn't just me, it was a bunch of different people. And even some nursing supervisors and some health coaches that we initially started this with. So we didn't even initially start it with the providers. We said, let's start with the health coaches, do some training on motivational interviewing with them to see if we could get them to potentially move the dial with some of the behavior change and the quality numbers that are important. So we started initially with them. However, we have some really strong senior doctors and in our residency programs that really believed in motivational interviewing. So they also asked us, how can we incorporate this into our residency? How can we do this as a part of, so when they come out of their residency, and it's at the time it was internal medicine. We also have family medicine now. How can we help them be more prepared to do this? So that's kind of ongoing all the time. We have another integrated health therapist who actually is embedded in the residency clinic. And so she sits right there with them, and she'll kind of poke her nose in once in a while and say, and help them with approaching a patient using motivational interviewing. Also, when I first came here almost 6 years ago, I would hear all the time, we don't have chemical dependency treatment here, which is true. We don't. Sanford does not have a chemical dependency treatment option. And so and I think I've told you guys that before, but we refer outside of here. And so the understanding was this patient needs chemical dependency treatment. We don't have it here. We need to get them into treatment. And we would get, obviously, as you guys know, we would get a lot of pushback from the patients. I'm not going to treatment, blah, blah, blah. So I started taking a different approach. You're right, we don't have CD treatment here, but we do motivational interviewing, and we do see these patients. So if they're not ready to go now, how can we shift the dial? How can we move them in a way that will help them? Maybe we know they need treatment. It's clear they need treatment and they need to stop using. They're not at that point yet. So the interesting thing is that I have learned too over the years is a patient always comes back to their primary care doctor, whether it's their primary care doctor or some other primary care doctor. And so even if they come 1 month, 1 day to see their primary care doctor and they don't come back for 3 months or 6 months, that's an opportunity. And so we can meet with them and try to do motivational interviewing with them each time and try to move the dial on where they're at. Hang on 1 second. Okay, sorry. So, and that's kind of how we have now gone from we don't do CD treatment to how do we still help these patients? How do we not let them fall through the cracks and still be available to them? We are involved in some of those, the behavioral health people, the integrated health therapists in the clinic, but sometimes we're not. Sometimes the providers, if they feel comfortable, will be the leading person on that. And then they'll come and consult with us and say, I'm really struggling with this patient. What do I do? What do I say? Because frankly, they're refusing to meet with me, which is okay. And some of the language too around like, this is what I can offer you. This is what I can help you with. Let's think about this a little bit differently. That the question I think too that Dr. Carpenter had mentioned, that help me understand that. Help me understand this. You said this, help me understand that. I say that probably once or twice a day because that is a very good open-ended question. It's not going to stop the conversation necessarily. And a lot of times will help the patient get to think about what they're saying a little bit differently, like what they're thinking in their head and what actually comes out their mouth doesn't always match, and they don't always catch that. So if you say, help me understand that, they usually can come up with something. Open-ended questions are hard, but they're so, so important. And like Dr. Carpenter said, we in open-ended questions for a social worker, they're like pounded into our heads starting from undergrad. We have to like literally sit with another patient, another student and practice them. We're not allowed to use closed-ended questions. So that might be something, you know, if those are hard for you, because they are. It's not a yes or no. It's not a yes or no type of question. So a lot of times I hear this a lot. You're not using drugs, right? Or just you're not, just yesterday, actually, I went to my own primary care doctor, and when the nurse was rooming me, she said, and no drug use, right? I said, no, but that is a very like, oh my gosh, if I really was using drugs, I'm not going to tell you. So those judgmental, closed-ended questions that we don't even really know we're saying that. I mean, the nurse was great, but she didn't even really know that that's how it was coming off. So a lot, especially, you know, with adolescents, I'll say, tell me about your pot use or tell me about your alcohol use. And they're like, what? How did you know I was smoking pot? That's what they'll say. How did you know I was smoking pot? But so tell me about this, which leads to what Dr. Carpenter, I just really, really wanted to reiterate, the be curious. When we were training people, we typed out like a card. We put it on a card, and we put it on the nurses' computers, the providers' computers, and it was the saying, "Be curious, not furious." Because if we remind ourselves that, be curious, get to know the patient's story. Why is it that they're calling you for a new refill? Why is it that every time they come in, their blood pressure is raised because they're intoxicated? Or why is their blood pressure raised? Well, because they're intoxicated. That was really helpful from our standpoint. That was really helpful for the providers to think of it and the nurses to think of it in a different perspective, because we do hear like they're a difficult patient, they're non-compliant, they're not listening, they won't listen to me. And that is extremely frustrating. So when we can think about it a little bit, like, be curious, not furious. What is going on with this patient that's causing them to be quote unquote non-compliant or difficult or whatever?
Hey, Bethany?
Yeah.
This is Lisa. I just wondered, could you maybe talk a little bit about the agenda setting? I want to make sure we leave time for Grant's case in terms of tangible first steps that people could move toward.
Absolutely. So something that we did with when we started in our primary care clinic to train the people of the primary care clinic. We started like with the little things that I'm talking about, giving them just little tidbits, like, what can I say here? What can I say there? But what we also did, and even just as soon as recently, we provided education on agenda setting. And the reason for that is because we asked our providers, what is the most difficult thing for you? What's the hardest thing? Or what would be the most helpful for you guys? And the feedback they gave us was, when I get stuck in the room with someone and I can't get out, and then they come to me with a list this long of stuff they need to talk about, and I have 10 minutes or I have 5 minutes and I'm already behind, and I don't have time to hear them cry, and I don't have time to argue with them, and how do I get in and get out with what they need and what I need? So we did some training with the providers on agenda setting and how can we get your needs met, how can we get my needs met, and everybody's happy. Not all the time, but so that's what we've been doing, even as it's recent, is providing education just in little snippets. So agenda setting, and we go as we need to, but that's kind of where we started.
So Bethany, you have developed a little bit of a curriculum to help providers just learn some simple agenda setting according to the principles of motivational interviewing. Am I remembering that correctly?
Yes.
And the feedback that you've gotten from your primary care providers has been really, really positive about that. Is that right?
Yeah, absolutely.
Okay. So the thing that I wondered was that if the audience could just give us maybe a quick sense of thumbs up or thumbs down about, would that be worthwhile for the participants to work through some tips so that you have some baby steps toward using these skills in a tangible kind of way. So could we just open this up for a minute and ask people, are we going down the right track? Would that be useful to you? So don't forget to unmute. I think Kylie has us all kind of locked down, so you have to unmute yourself.
I saw a thumbs up somewhere.
Yeah. I think that was Kurt.
Can you hear us?
Yes.
Mm-hmm.
So this is the Minot Center for Family Medicine, and our psychologist is saying she would love to have the curriculum so she could present it to our residents at the clinic here. It'd be very useful for them.
Okay. Anyone else?
This is Dave Schmitz here at the host site in Grand Forks. I would just make the comment, as I usually do, trying to contextualize this to both opioid use disorder, MAT, and a rural setting, and myself being a provider who's on call, I find sometimes I want to do motivational interviewing and use some of the skills that I have, but I find that the patient is high, or the patient is intoxicated, or the patient will be going into withdrawal. And so one of the questions and context I would have is, I was taught that, well, maybe you want to talk with somebody a little differently when they're in the contemplation stage than when they're in the pre-contemplation stage. And maybe I would talk with them a little bit differently if they're intoxicated versus not intoxicated versus in withdrawal. And with opioid use disorder, you may not have a lot of time where they're not either intoxicated or in withdrawal. And the other is, do I do this in the emergency department? Because some of my patients I'm admitting are leaving against medical advice and being discharged, and they're not coming into the office setting. They're not coming into the primary care provider. They're being seen in the emergency room setting, and they're being seen in the hospital setting for a short time before they are leaving the hospital setting. So I just would like to also add in some of that complexity, because I think if I had the patient in my clinic primary care setting, that would be great. But some of the seriousness of this disorder is that where we're finding patients is in these circumstances, in settings that I don't want to do harm. I don't want to ruin the opportunity for the time they're in the primary care clinic setting, but I also want to hopefully be able to intervene in some of the most serious cases.
So that's a really great observation, Dr. Smith. I think that when we were talking about how to make this relevant for providers, it's important to be able to develop a sense of some basic skills that are applicable in a lot of different settings. And so I think what Bethany probably would answer to that, if I'm correct, is that there's probably a place for agenda setting in a lot of different settings, and that you really can't do harm understanding how to close the gap between what your agenda and a patient's agenda is. So we thought this would be a great example of how to find a basic tool that you could apply, not just in opioid use disorder or alcohol use disorder, but with patients who are struggling with health conditions. Bethany, anything you'd want to add to that?
No, I agree. And I would say you can use motivational interviewing anywhere. It doesn't have to be and it doesn't just have to be agenda setting either. There's definitely, in Dr. Carpenter can chime in too, but it can be used for sure in an emergency room setting, especially if they're coming back. So if they're coming back over and over and over, even them coming back may be an opportunity to use motivational interviewing to help me understand what's keeping you from going to the primary care doctor I'm setting you up with to coming into the emergency room. So, I mean, there absolutely that you can use it in the emergency room. When they're intoxicated, that's a little bit different, because obviously when someone's intoxicated, it's impossible to really do anything, have a normal conversation with them.
Yeah. And I think you have to think about how cognitively available someone is or is not in a setting. But is there anybody else who would like to chime in about whether this feels like it might be relevant to go down this road as we develop curriculum? Because I do want to get to Grant's case presentation here. Okay. Any other comments or questions for Dr. Carpenter before we move on? Okay. Grant, are you still with us, or did you make it here to us from your emergency room where you may or may not have needed some motivational interviewing skills?
I am here. I'm with us.
Hi. Do you want to go ahead and present the case that you have for today?
Sure. Well, my name is Grant Lanoy. As you know, I'm a physician assistant. We're in Candu, North Dakota. It's a critical access hospital, rural healthcare clinic. I'm fortunate to be sitting here with my two nurse practitioner colleagues who also are doing MAT. And we also have the nicety, I guess, of having Heartview Foundation inpatient treatment located in Candu here as well. They can have up to 16 clients out there at a time, I believe. So anyways, this particular case, I have a 30-year-old female who came to me. She had been on buprenorphine only because she was pregnant. She had come to me on the 18th of January. She had a baby on the 3rd of January via C-section. She was discharged from the hospital on the 5th. Had seen another provider prior to seeing me, I believe, after her surgery. And when she was discharged from the hospital, that surgeon discharged her with 40 oxycodone 10 milligram immediate release. For what reason, I'm not sure if he was not aware of her participation in past substance abuse, but I feel like that was an error on both his parts and I suppose the patient's, being that she did not communicate her substance abuse disorder to him. So anyhow, she comes into me. She was on straight buprenorphine yet. We're going to be in the process of transitioning her to a naloxone containing component or medication. So she's on buprenorphine 8 milligrams, half a tab 3 times a day. And she comes into me and she tells me that she was now taking 2 whole tablets every day without anybody's consent. She just went and changed the dose on her own, which is a violation of our contract. But after some discussion with my colleagues and given the current situation, it sounds like she was taking her oxycodone as prescribed for her pain. However, I've talked to other ladies who have C-sections and they just have done ibuprofen and Tylenol. But of course, you give a substance abuser 400 milligrams of oxycodone, they're probably going to use them. So she increased her buprenorphine on her own, which we did not approve. She came in and instead of, terminating her from MAT, I figured at this time it was best for both her and her newborn baby that she be kept on buprenorphine for fear of relapse and her losing custody of that child. So I did increase her buprenorphine to the 8 milligrams twice a day, and I think she was splitting it, so she was taking 4 half tabs every day. But it's it kind of just shows that every scenario is unique, and that we can't really have, I don't think, black and white for these patients. Like, given her and her situation, I think she's very high potential for relapse, but at the same time, I think we had to give her another chance in order for her and her child to have a chance at making it, and her being able to keep her child at home and doing what's best for their family. So we gave her another chance. We are still seeing her. We're planning on drafting a letter to that provider who prescribed her so many oxycodone to kind of see where the ball was dropped, if he didn't see that or what his intention was behind that, I guess. So I'm not sure how everybody feels about what I did there with continuing her on that, but I guess that's like I said, it's kind of a gray area with some of these patients, and I did what I felt was appropriate. So if anybody has any input or questions, I'd be happy to hear them.
Do you have, obviously one of the things I hear you asking for is feedback about maintaining a relationship with someone who's quote unquote non-adherent or non-compliant. So we'll ask Dr. Carpenter and the group that your colleagues, do you have any other questions about this case that would be helpful to you or that you'd like input about?
I just kind of, I just wonder how everybody else would have handled the same situation given the newborn at home, and it was complicated by the oxycodone that she was discharged with. And just curious if everybody else would have handled it the same way or if they would have done something different or what.
Okay.
I guess another question for me is, we're all going to have patients who are undergoing surgery or things like that, where there's a possibility that they'll be prescribed opiates for pain afterwards. And how are some people handling that situation, I guess, is our question.
I think it's the patient's responsibility to inform the surgeon that they are taking a buprenorphine product.
Sure.
That's what our pain contract says. And if they don't notify the surgeon or the other provider, then they in a sense have voided their
contract.
Pain contract. So hopefully they can read that. I mean, that's how we're trying to protect ourselves.
Yep.
I don't know how other people do it, but that's one step that we take.
Grant, this is Orlin, Dr. Jackson from Beulah. I want to thank you for
Hey.
all the thing. We met over the phone the other day. Anyway, the patients really appreciate what you're doing. But what we do with our pregnant patients is, one, we get on the phone right away with the OB provider. We call them, let them know, and then I send them a letter, and I'll give it to you if you'd like, but it's talking about Suboxone and methadone and what you should do, the importance of breastfeeding with it, and what we're also doing, seeing tons of patients in the ER, and the patients tell them right away, don't give me any fentanyl, don't give me any Dilaudid, but they have no clue. They have no clue. They don't know what to do. So what we're going to also do is give them a card. There's a Suboxone card that they have that is a handout, and it's not really very good, but we'll print out something better that say, this is what we need to do. We need to use Tylenol, we need to use acetaminophen, we can use IV Toradol, we can use other things, but do not give my patients Dilaudid, do not give my patients fentanyl. The providers really, the patients actually know more about this than the providers, even the ER physicians in the big cities. So once again, the patients think the world of you, and I appreciate what you're doing. We just saw one of your patients today, and talk to the providers, let them know right away, and then we're getting a handout to say this is what you do. Have that handout for the
we give them, it's like a protocol when they I guess when they get pregnant, we give them this protocol, and then we also call their OB, and Dr. Jackson communicates with their OB provider, and we can send them that protocol too, just so that the provider and the patient both have that, and it works for us.
I'd be interested in seeing that, if you guys would be willing to share that, or if Kylie wants to distribute that to the group if you're willing.
Absolutely.
So I was just going to say, it sounds like you're kind of developing a, if you will, a best practice around helping to inform your colleagues, the network of colleagues around you, so that when they run into these situations, they have some ideas about what to do. So I think there's actually two things, sort of two ideas or dilemmas floating here. One is the dilemma about a quote-unquote non-compliant patient and whether you would terminate the medication-assisted treatment if they violated the contract. The other is how to manage concurrent medical problems or situations that cause acute pain that may need or where opioids may be considered. I think I see Dr. Patel on the call over there, and if you recall, I think he knows a thing or two about OB. Are there any other spoke sites that want to ask or step in, or do we want to ask Dr. Carpenter, Dr. Patel, any thoughts about this, or if they have any other best practices to share for colleagues?
So thanks for that presentation of the case. I agree in the sense that making sure that we're having discussions with our colleagues, it's really important. Yes, reaching out to the provider, trying to get clarification on the thought process is really helpful. Instead of writing a letter, maybe a call, such as the prior person said. Things can get lost, misunderstood. It can show up in a medical record. We don't really want to, I would suggest that we not be in such a manner of maybe alienating the provider or the prescriber. Another question that came up was in terms of how surgery impacts these things. As you all hopefully remember, I am Senior Medical Director over at Brightview. I work with Dr. Carpenter, and my background is obstetrics and gynecology. Yes, some patients will do well with 3 days of inpatient medication and then out the door with ibuprofen, and others just don't. It really is the healing mechanism, and you may or may not have heard the term bad protoplasm. Some people just don't heal well, and it's okay to send patients home with pain medication. It absolutely is. But prior to going home with the pain medication, there should be a plan in place. And that's where having that discussion with that surgeon can really come into play. What we do with our pregnant patients is between 32 and 36 weeks, we send out a letter to the OB that basically says, hey, this is what our recommendations are for pain management. If you agree, great. Let's make sure that everyone's on the same page. If you don't, please give me a call and let's have a discussion about it. Communication is always going to be key, but both sides have to play, and that always doesn't happen. So in terms of actually discharging patients, there needs to be some flexibility, hopefully, but yes, there needs to be also the accountability that patients have. Having that discussion with the patient, it sounds like the team that presented has a really good rapport with their patients. So just having the discussion on what was going on. Why are you taking more? Understanding that after pregnancy, especially, or any other surgery, patients are going to be inclined to have a different pain threshold.
Is there any input? Anybody have any thoughts or observations about the patient violating the pain contract? Would you, I think one of the things that is a question is, would anyone handle that differently? Would you change that?
I'd like to weigh in. Out of curiosity, what dose did you continue her on before I keep talking? I'm so sorry. Is it Grant?
Yes, yeah. You know what? I did increase her dose to 2 8-milligram tablets twice a day, and I think she was taking those in half, so 4 milligrams 4 times a day. And we kept her on that, and the plan is going to be to back her back down over the course here, and I believe we have her on a naloxone-containing component now. Is that
I just started today. Yeah, she's on Subzol TID.
Okay.
At 8.6, 2.1. I think.
So with that, I mean, I think that, I mean, that it's, first of all, there really is in many ways no right or wrong. The interesting thing as you were talking about that is that the exchange of using medication-assisted treatment can become super emotional. Like somebody else could hear that and be like, how dare you? I mean, we might not say it, but how dare you overtake my medication? My license is at risk. I mean, there's lots of things that go through our head, or just the idea that for some reason too, specifically, we sometimes hold these patients up to a standard of perfection, whereas we don't for many of our other patients. And it might just be we're more vigilant just because of the issue of, yeah, maybe they are more likely to use or break the treatment contract. And, you know, there is this kind of dance in line too. Treatment contracts, if they become black and white without any kind of gray, they can be just that. They can be too final. I mean, one way to use treatment contracts is to expect that some people are going to bump into the boundaries of that. Then you discuss the boundaries. So whether people want to have a 3-strike and you're out then like, hey, we've talked about it twice. We've engaged you twice on this now. Like, don't do it again. I mean, that allows for some flexibility. Because again, I mean, I think that was actually a super great call. Even if she wasn't pregnant, even if she didn't have a kid, you know, let's say it was a guy who just got out of prison and has a history of like dealing tons of drugs, but this is my first time with him. Theoretically, this may be his, you know, first time in treatment. I think it's okay to take a risk and say, listen, that was a really bad idea. Don't do it again. But we'll move forward in this way. Specifically, and then Dr. Patel, you may have to correct me on this, but to speak more to the pain management idea, it is kind of, well, it is important to talk about just because if you look at the different options, one is, and some people try and do this, it's, well, increase the buprenorphine to help address their pain for this minor procedure. And this was something that it wasn't until I started working at Brightview was then kind of realizing that, yeah, we shouldn't be doing that. There is a restriction that the medicines that we use to help people with opiate dependency, we only use FDA labeled products. And also these medicines are only supposed to be used for that specific indication. So to use medicine specifically for the purpose of pain, like, I mean, there is Belbuca, which is a buprenorphine product for pain. There's a buprenorphine patch. So it's not that this medicine can't be used for pain, but it goes against that data waiver, I believe, that we signed to actually then use it specifically for pain. So that's one thing to keep in mind. Two, which I think is what a lot of hospitals are used to doing, is saying, okay, stop your medicine 3 days before you come in and we'll manage your pain. Well, that's a horrible idea, just because, like, if we could have our patients not take their medicines for 3 days and be okay, this would be way easier to treat. I mean, I get it too, because they're trying to, on their end, especially, you know, if this person needs anesthesia or whatnot, they want the slate as clean for them as possible. And again, Dr. Patel, this is where I need you to help and chime in maybe, but ideally, the theory and the goal is this, you know, buprenorphine, we use that for treatment and symptoms of addictions, not for pain. And that basically kind of brings them up to kind of a therapeutic threshold. Yeah, it's going to blunt some of the opiates that they use for pain or for purposes like that, but to keep them on buprenorphine and then attempting to treat the pain on top of it with appropriate pain medication, knowing that they may need higher doses either because of their tolerance or because of the fact that they're on buprenorphine. Is that completely incorrect, Dr. P?
No, that's right, and it's also interesting to note that there are different protocols depending on what part of the country you're in. University of Michigan will typically ask their providers to stop prescribing for 5 days prior to major surgery. Boston University tells people to continue through. The literature most recently from the Journal of Anesthesia or Anesthesia, whatever their main journal is, says that they should continue the medication of buprenorphine and then adjust the dosing as tolerated. And that's why it's really important to have that discussion when we know, hopefully for the most part, we know that the patients are going in for surgery. So giving the patients that opportunity during their anesthesia consult to have the discussion of what the expectations are going to be, whether if the anesthesiologists and the surgeons want them to stop the medication, it's okay. It's not, but what are we going to do? Tell them not to have surgery? In some cases, we can't do that. It's just how we're going to monitor them afterwards and helping and having that understanding with your colleagues that are performing the procedures.
So, Grant?
Do you mind if I just add one thing, Dr. Faust?
Absolutely.
This is Amy. I'm a psych pharmacist in Fargo, and I had the pleasure of hearing Dr. Henke speak. Those of you that are at Heartview, maybe you've heard her say this exact thing, but I'm totally borrowing her words. She was talking about this very issue about if people have a relapse or they break the contract that they're on when they're on MAT, what's the best thing to do? And she used the analogy of a diabetic patient. You know, if they become non-compliant with their diet or with their insulin, we're not going to kick them out of the clinic and say, sorry, I can't take care of you anymore. On the contrary, we're going to approach them with a whole team approach. We're going to introduce them to the dietitian. We're going to introduce them to the exercise folks, and we're going to increase their dose of insulin so that they can sort of catch up and manage their diabetes better than ever before, perhaps. And of course, bring in motivational interviewing and discuss the reasons why this kind of thing happened. And so I think just thinking about that analogy, of course, the disease states are different, but the analogy of are we going to care for the patient and try to set them up for the best future, I think helps keep it in perspective about what the contract is really for.
This is Dr. Falcon at Minot. I have a comment if you don't mind. Can you hear me?
Absolutely. Go ahead.
I would say that analogy is a little bit different for a diabetic than for a pain patient because the DEA is not involved with that diabetic patient. And there is risk of loss of licensure associated with, you know, continuing to prescribe to somebody who is abusing or suspected of abusing. So that would be a little bit different case, and I don't think they quite equate.
That's a very fair point, but as you read the DEA, the law, the way it's written, it gives a lot of flexibility for the provider to be able to document the justification of the change in how they're approaching that patient. So whether if there's a suspicion of them misusing or doing anything that they're not supposed to do based on the way that the actual prescription is written, anything as simple as bringing them in for an additional visit, doing a pill count, having additional toxicology testing done. Yes, you're absolutely correct. There are concerns involving licensure, but they do leave a lot of flexibility if you document appropriately.
Yeah, if I can absolutely to Dr. Patel, I absolutely agree with that. And then to the person that just made the comment, no, it is valid. And Amy, I know that, so Amy was the one that said the analogy, and I've heard that analogy used before, and analogies are important because, you know, but not one contains the absolute truth. It is important to listen to that analogy and just, you know, think that, you know, I wouldn't do this for a diabetic patient. So should I change my boundaries? Should I look at this differently? And that kind of may invite somebody who's more strict and stringent to have a more open view. But sir, to your point as well, at no point am I ever going to refer a diabetic to a residential level of care. So at some point, it does become different. But again, exploring the truth within the analogies, I think is important.
This is David Schmitz with maybe just a clarifying question. So, Dr. Falcon, I really appreciate voicing the other side of this, I think, discussion. Would any of the experts out there on MAT say that the scrutiny on MAT prescribing is equivalent to or similar to or not similar to the scrutiny on opioid prescribing outside of MAT, as far as holding patients to contracts, et cetera?
I think it's really regional. And the reason I say that is here in Greater Cincinnati, the field agents have a different perspective than what the national people are saying out of Washington in terms of the scrutiny. And this is DEA for buprenorphine. So I think that it would have to be a discussion that you have with your local state medical boards to have a better understanding.
This is Dr. McCoy. The other issue is, you know, what are the resources of the particular clinic? You know, if you use the diabetes analogy, do you have a dietitian there? Do you have other peer supports? Can you assist in groups or teaching other levels of care? You know, some of the clinics and some of the providers, I think, that have been talking about that might have more resources than another individual or another clinic, where you really do have to set firmer limits because the risk is too high because you don't have those resources. So I really think it is case by case and system by system.
Absolutely. And just to add on to that, again, it is, especially in a place where we're trying to draw more providers because there's a limit to that. We have to have a waiver and you can only have so many. And that's why to grant, there is no, you know, right or wrong. There is, you know, there are standards and it's important to be aware of those, but whether, you know, the patient was terminated and referred, we don't, you know, we wouldn't just terminate. We would hopefully then say, well, I can't do this. Here's a professional that can. But it's important though to become intentional and always, you know, I mean, that's why discussions like this are so helpful. You know, we may all leave and think, well, maybe I could be more permissive here, or maybe I should be more strict here. But at the end of the day, it is important to identify. So for example, in this case, like, so for me personally too, if somebody is new within the clinic, 16 is kind of my magic number, whereas like if they were on 12 and they said that they overtook to be on 2 tablets a day, and it's their first time, in my mind, the limit I've had to help be permissive, but also to set limits is that, well, you know, don't do this again. Sometimes I'll maintain them on 12, sometimes I'll bring them up to 16, but for me, if they go from 16 to 20 and they say, you know what, 20 worked great for me, I would say, well, that was totally not what I did. You're still a part of the clinic. Unfortunately, you're gonna have to wait until your next fill though, because you didn't use it the way I told you to. And that's not to be punitive, but it's just super important that we do things, yada, yada. So it's just important to know what, and they can change, and it's not like we have to adopt somebody else's boundaries, but it's just important to know, because if we treat everybody differently, that's really hard to manage.
Dr. Carpenter, I was thinking about what you just said and in the context of Grant's description, and I think this is an evolving story. You know, and when we talk about contracts, in some ways they're a basis for understanding and for ongoing conversation. So it's a way of making certain that we document we've had a conversation about risks and what's expectations with a patient. But for Grant, you know, he did that, and the patient came away and didn't follow that contract. So now he's coming back, and it's a basis for more conversation. He level set again and said, you know, that was actually not the contract, and he pointed out the gap, and he said, don't do that again. And at some point down the road, and he's weighing the risks and benefits here, because he says, well, there's risk because the patient violated the contract, but there's also risk because this is a patient who's a new mother and there's a baby involved. And so, you know, I'm gonna live in the gap here for a while, and I'm gonna balance these risks. And then as we march forward in time, perhaps we'll need to check in with him at some point and ask him what happened. Because it could be that the patient will continue to violate the contract, and he may be having a very different conversation down the road, right? And he may at some point have to come to the point of saying, you know, we can't continue to do this. Or he may have helped convince the patient that she needs to be aligned with him a little more closely. Would that be a fair assessment?
Oh, I think so. It is evolving. And I'm sorry, Grant, were you going to respond to that?
No, I was just I was going to agree with what she was saying.
So we've been talking a lot about you and your case. Thoughts, feedback?
No, I think that's all good information, you know, and I think that's as far as, you know, managing pain after these procedures and stuff like that. Yeah, from what I remember learning, you know, keep them on there, buprenorphine, and then they may require higher doses of opioids if that's the way we got to treat them. And yeah, I guess just we do need to really involve everybody in, like you said, you know, if somebody's gonna have a surgery, they should, you know, usually it's not, hopefully not emergent, and we should know ahead of time, I guess. Like I had another patient who was planning on having 6 teeth extracted at one time, and that was gonna be an issue for her. And we talked about, you know, she wanted to try to avoid opioids, but we're gonna keep her on her buprenorphine and just kind of take it day by day. I wanted to follow up with her the day after she had her dental extraction to see how she was doing. Unfortunately, they weren't able to proceed with the dental extraction because she had an ongoing abscess or infection that they weren't willing to work with. So that's been postponed. So maybe there could be a case for another time.
Grant, I just wanted to say thanks. This is Dr. McLean for presenting that case, and it sounds like you have others. Kylie sends out the cases to us before, you know, the day arrives, and you know, I just thought these are great.
Couldn't just text
Encourage
in the window.
other people out in the community. Bring them forward.
No.
I couldn't agree more, and we really appreciate this. It's not easy to sort of be the early ones and bring forward difficult cases that may or may not showcase your skill set in the most positive light. So being humble and as Dr. Carpenter talked about with MI, being curious about what are alternative ways to think about things is really helpful. Are there any other thoughts, questions, observations before we conclude for today?
Just to mention one other thing too, and again, this is where, you know, in medicine there are some absolutes. So one of the things that was mentioned was about the dosing, you know, like 3 times a day or 4 times a day. Although some providers I know do that, and they find it's very helpful to address 24-hour coverage. You know, one thing, it's really interesting. Everything we do, even down to the prescription, is an interaction. And we might just totally take it for granted, but especially if we're working with a population that may kind of make boundaries kind of fuzzy. You know, as an example too, and I'm not saying that it would have been different in this case, but one of the things that sometimes people hear when it's 4 times a day, sometimes they magically throw in that as needed kind of thing. So one of the reasons that I've chosen not that it's, you know, right or wrong, but not to do that is that, you know, taking a medicine 4 times a day for anybody, the healthiest person, is super difficult to do. And what happens when you miss the 4th one? Well, I was good with 12 today. I had my 4, and I didn't take the one from yesterday. You know, maybe it's okay that I add that, and then all of a sudden they're in this kind of like slide or slippery slope scenario that, you know, for some people that is totally appropriate, and it is case by case, but it may be a beneficial thing, especially for her to just say, you know what, this medicine was kind of designed for once a day dosing. That may mean that sometimes there's symptoms at night or in the morning, but that actually does happen even for successful recovery, even with successful medication treatment. Sometimes there's still breakthrough symptoms, and that's where the therapy techniques come in. But just something to think about regarding that.
Yeah, and with the multiple day dosing, I know that compliance, goes down the more you have doses throughout the day. But with some of these patients, I feel like they get something psychologically about taking something every so often. Like I don't know if I'm explaining it right, but if that makes sense, rather than taking something once or twice a day, they feel like taking something 4 times a day that makes them feel better. And I think that they are less likely to miss a dose because it does help with their cravings and their symptoms.
No, and that's one of the beauties of, again, as Dr. Faust said, that living in the gap. I mean, there are times that, I've done that for, I've taken somebody's Seroquel and I've made it 3 times a day, not because I think that is what's, medically the best thing, but for some reason I've weighed it out and I think, listen, as opposed to adding or increasing another medicine, let's just try this. So, no, I mean, the rationale is it sounds like you had justification for it. No, I think that can make sense.
And this is Dave Smith. I just want to say I have a lot of respect for this case and the really rich discussion it's brought out. So again, I just wanted to mirror that and say, as a family physician with real experience, this was a great case and discussion for many reasons.
It was.
Thanks again.
It was. Yeah. Well, thank you, everyone. We're at time, I think. We want to remind you again to please do your post-test. And if you do the feedback forms for us, that is really, really meaningful and helpful, because we are learners here and we're trying to move this forward in a way that's meaningful and helpful to you. So we really need your support and feedback. So can you remind us from the host site there, when is our next presentation? What's the date?
Our next one will be February 28th, and Grant will also be presenting a case there.
Okay. Well, Grant, you are a rock star, and we appreciate that. So 2 weeks from now.
We got cases for every day if you want, but I'm sure other people have cases too, and that would be appreciated.
Yeah. Well, when they're not so shy, we'll get them to come forward. But we appreciate you helping us out with this. So, thank you, everyone, and happy Valentine's Day. Bye-bye now.
Thank you.